Dear colleagues, dear students, we continue the psychiatry lectures from the University of Page. This is the 5th year, first semester, and today's topic are psychosomatic illnesses. What is the definition of a psychosomatic illness? It's very important to understand. These are diseases with a real organic background, with a multifactorial etiology. So, real organic illness, for example, essential hypertension or ulcerative colitis, and the background is multifactorial, not only one cause, but many factors are contributing to the background. And beside the genetic, the immunological, the environmental, for example, as nutrition factors, psychological factors also play a role. And this is what we see in many psychosomatic illnesses, that genetics, for example, of essential hypertension, the amount of salt which is eaten by the patient is important, but psychological causes, for example, stressful life, is also very important. So this is the multifactorial etiology. Here, it's very important to understand and very important to highlight and emphasize the fact that these are true organic illnesses, because previously there was a lecture on somatoform disorders or somatic symptom disorders. You remember, for example, conversion disorder, hysteria, that the patient has paralysis or blindness or deafness without any organic background. So in the case of somatoform disorders, there is no organic background. In the case of psychosomatic disorders, these are true organic problems. So this is the great difference between the somatoform group and the psychosomatic group. So you shouldn't mix them. Very important to differentiate, but here also the psychological causes are important. What is the psychosomatic illness, or we can say what is the psychological component in the multifactorial etiology of psychosomatic patients? The first is a personality trait which is called alexithymia, which means that the patient has an inability to express, to verbalize his effects, to express and verbalize his emotion. The patient doesn't know that he is angry. The patient doesn't know that he has an inner wish to maintain a dependent relationship towards somebody. So this is what alexithymia means. Alexithymia means it was first introduced by Sifnaos in 1973, and the first alexithymia was seen as a specific personality trait for psychosomatic illnesses. In the very first phase, it was so that every psychosomatic patient has alexithymia, and every person who has the alexithymic trait, the alexithymia as a personality trait, will develop psychosomatic illness. Later it became true that it is not the case. It can happen that there is a patient with psychosomatic illness who is not alexithymic, and it also can happen that somebody has an alexithymic-like personality and never will have psychosomatic illness. So it's a non-specific sign, but important characteristic. The second is type A personality, which is characteristic typically for patients with cardiovascular problems, hypertension, acute myocardial infarct, angina, where the patient has a feeling that he has many duties. The patient has a very stressful life. The patient cannot be satisfied by finishing something, but the patient again and again feels that he has urgent duties to do, and this continuous feeling of never being finished, never finishing issues is characteristic for patients with type A personality disorder. And the third psychological factor are negative life events, that the patient loses an important person, the patient has financial problems, and many other negative life events can be considered as important in the development of psychosomatic problems or worsening of the symptoms. An example for this negative life event in the case of psychosomatics is that there is a patient with ulcerative colitis who is in remission with salazapine. The patient is symptom-free with salazapine for years, and the patient mother dies urgently and recently, and the patient loses the mother, and because of this negative life event, the well-remitted ulcerative colitis starts to show symptoms again. Bleeding starts, abdominal pain appears, and so on. So in this case, the negative life event somehow contributes to the worsening of the symptomatology. The term was introduced by Hendroth in 1818, the psychosomatic concept, and also Jacobi in 1822 spoke about the somatopsychic concept. Psychosomatic concept, which I was talking about in the previous minutes, the somatopsychic concept is a little bit different, which means that somebody has a serious illness, and because of the serious illness, the patient secondarily develops psychological or psychiatric problems. So somebody needs to face with the fact that he has a serious illness, and it secondarily leads to depression or crisis or something like this. Grodek was a psychoanalyst and internal doctor in Germany between the two world wars, who established the first psychosomatic clinic. He was a great friend and contributor of Sigmund Freud and Sándor Ferenczi, and in his clinic Grodek introduced a psychoanalytically oriented internal medicine, we can say, and the whole psychosomatic concept, which was started in Germany, can be connected to his name. Alexander, Franz Alexander, who was Hungarian, who had a Hungarian origin, he was born in Hungary. His original name was Alexander Ferenc, and later in the United States he became a very famous psychoanalyst and is important contributor to psychosomatics. Alexander in the 1950s very much contributed to the development of psychosomatic medicine. The psychosomatic illness is theoretized and considered in the frame of a biopsychosocial model, which is named by Engel. And recently, a modification of this model was introduced, the biopsychosocial spiritual model, where biology of a person, genetics, constitution, the psychology of the patient, the different negative life events, personality traits, the social factors, environment, and financial problems, and other issues, and the spiritual aspect of a personality is also considered as important. What the patient feels as important in life, what is the goal of our life, why we are living, what do we think about our personality, what do we think about our life, what do we think about our relationships, what are the goals of our relationships. So all these are involved in this model, the biopsychosocial spiritual model, and recently this is a kind of holistic approach toward illnesses in the psychosomatic medicine. Alexander collected the background of psychosomatic illness as the following: hereditary factors, genetics. We know that genetics are many times important, essential hypertension as a genetics and other illnesses too. Constitutional factors, temperament, personality traits are important. Childhood illnesses, which results in special disposition. If somebody was hospitalized many times during childhood, it can lead to a kind of sick role, it can lead to a kind of socialization which was very much influenced by the continuous sick role. Nutrition is important, as we know, in many psychosomatic illnesses, not only in hypertension, but GI disorders and other cases too. Environmental, physical, chemical impacts are also important. Hormonal factors, we know that some illnesses are more common in females, others are more common in males, and psychosocial factors. So all these are important as a background of psychosomatic illnesses, and this is why at the very start I very much emphasize that psychosomatic illnesses are multifactorial illnesses. Many causes. You can see the many causes here. What is the Holy Seven? Franz Alexander gave this funny term to 7 illnesses, and he said that these are the so-called leading or essential psychosomatic illnesses, and this is what is called the Holy Seven: asthma bronchiale, ulcerative colitis, essential hypertension, neurodermatitis, rheumatoid arthritis, duodenal ulcer, hypothyroidosis. These are the 7 classical, we can say, psychosomatic illnesses described by Franz Alexander under the name the Holy Seven. Also, Alexander's focused on the specific psychodynamics of certain psychosomatic illnesses, and he differentiated 2 psychodynamic focus. One is the so-called aggression focus. When the patient has a problem with aggression, the patient cannot cannot repress aggression, or the patient more commonly very much suppresses aggression, cannot verbalize aggression, cannot express aggression, and this can lead typically to cardiovascular diseases. So the patient has a problem with aggression management, we can say. This is the recent term. Then it's a kind of risk factor towards cardiovascular diseases. The other is the dependency focus, when the patient has a psychodynamic problem around dependency, and typically skin, lung, and gastrointestinal disorders are related to this dependency focus, this dependency problem. This is why in the previous minutes I gave you the example that patient with remitted ulcerative colitis on salazopirine, and in the same medication the patient loses her mother, and this negative life event leads to decompensation of the illness, and this is why, because the dependency focus is the psychological background of an ulcerative colitis, of a gastrointestinal psychosomatic disorder. There are recent scientific fields which I'm very much sure that we have heard about during the 3rd and your 4th year from medical psychology or medical anthropology or other subjects have dealt with this, maybe physiology also touched these topics. For example, psychoneuroimmunology, which focuses on the relationship of autoimmune, allergic, inflammatory processes and psychological factors, the interaction, the relationship between these. Psychoneuroendocrinology, the HPA axis disturbances and stress response, the pathology of the stress response and psychological factors, the relationship of these is a topic of psychoneuroendocrinology, and psycho-oncology, which deals with the relationship of malignant diseases and different personality factors. So these are recently developing scientific topics and fields which were very influential in the previous decades. Let's see cardiovascular psychosomatics shortly. Here the type A personality should be mentioned, which means as a kind of manager personality, no enough time, the feeling of no enough time. I have many duties I cannot finish, new and new duties appear, new and new things appear to be solved, and the patient has this chronic feeling of never finishing things. The other are depressive symptoms, which is also important. There is a high comorbidity of depression with myocardial infarct. There is a phenomenon which is called vital exhaustion, which means that before an acute myocardial infarct, hours or days before the AMI, the patient has a very, very strong and very intensive feeling of tiredness. And type B personality, which means that the patient is full of negative affects and is also connected to cardiovascular psychosomatic problems. Acute stress, intensive anxiety, sympathetic activity can lead to acute cardiovascular event. So this is very important to know. Psycho-oncology as a field also more and more influential, mapping individual psychosocial factors that can play a role in the development in the course of the malignant disease. This is the topic, this is the essential topic of psycho-oncology, how individual psychological factors influence malignant diseases. Psychosocial factors can influence cellular immune reactions, contributing to cancer development and progress. And also important to mention that HPA-axis overactivity due to chronic stress can contribute to the development of certain tumors. Gallenus was the first who emphasized that melancholic women are more prone to breast cancer. So we know that breast cancer has many etiologies, genetics are important and other factors, but melancholia, depression can have a connection to this illness, in some patients, in the case of some patients. In the 1950s, 1960s, it was discovered that negative life events play a role in the development of cancer. The suppression of anger are common among cancer patients, and many clinicians speak about C-type personality or cancer-prone personality, where the patient is unable to express feelings, but he would like to do it, and the others are more important attitude somehow suppresses the expression of the patient's feelings. So the patient has a tendency, the patient has an inner desire to express what he is feeling, but the patient has a kind of external control, and he suppresses his feelings because what the others would say. And this kind of C-type personality is a risk factor for cancer. Another field, because in this previous slide I was focusing how psychological factors can lead to the development of cancer. But there is another case that the patient has cancer which maybe wasn't connected to psychology, or wasn't connected to psychological factors. Other factors led to the development of cancer. Environmental factors, for example, lung cancer and smoking and so on. And psychological factors are not important, they're not contributing. But another aspect, that if somebody gets the diagnosis of cancer, this means a crisis. It means a kind of emotional shock. The patient in every cancer case should face with the life-threatening illness, should face with the probability of death, and this means a crisis situation. It can mean an emotional shock. So the coping or feeling of insufficiency in the case of cancer is very important. We can see two types of patients, the positive patient and the so-called negative patient. The patients who are more active in their attitudes and flexible, who have good problem-solving skills, who show better quality of life and have a better cooperation, they can expect a longer survival time. In contrast, patients who use more an avoidance strategy, who are more passive in their coping strategy, who show worse quality of life and more depression, will show a poorer outcome. So better outcome and a poorer outcome can be based how the patient can cope, how the patient can adapt to the reality of life-threatening and serious illness. What can be the therapy of psychosomatic illnesses? And here we should emphasize all of them which are mentioned in this slide. First are the somatic treatments. So, as I mentioned during the whole lecture, psychosomatic illnesses are true organic illnesses. They need somatic treatment. Essential hypertension needs antihypertensive medication, and all the other illnesses in most of the cases need somatic treatment strategies, and these are done by the specialists who are involved in the treatment of these patients. But besides this, psychotherapies are also important, dealing with the psychological factors, dealing with alexithymia, dealing with negative life events, dealing with a special personality type, dealing with the crisis which appears in the case of a certain illness when it worsens and so on. So psychotherapies are important. And there was the German model, which is called the Psychosomatic Clinic model, which was based by Grodek, who I mentioned in the history part. Grodek, between the two world wars, established the first psychosomatic clinic in Germany, which meant that patients with these classical psychosomatic illnesses were treated separately from the so-called traditional internal medicine patients. And in these psychosomatic German model clinics, the focus is on the holistic approach. There are somatic specialists, there are psychologists, there are psychiatrists, there are non-verbal therapists, there are social workers who are trying to deal with the patient's many aspect, many-phased illness, and not only the somatic treatment and the psychological treatment, the social aspects are involved in this approach, and there are special clinics, typically in Germany, for these patients. In contrast, in the United States and in the American field, the consultation liaison psychiatry was spreaded, which means that there are no special clinics for these patients. The patients are in most cases treated outpatiently, or the patients are needed at a certain ward where the treatment is most important. And there is a continuous consultation between the specialists. The internal medicine doctor, the psychiatrist, the psychologist are in consultation, and they try to collectively and together introduce a special recommendation for these patients, and this is called consultation liaison psychiatry, which is nowadays very much popular and very widely spread all over the world for the treatment of patients with psychosomatic illnesses. At the end of this lecture, I would like to mention that there, as we know, in the field of medicine, or in all fields of medicine, the cooperation with illnesses is very difficult. There are many difficulties around the cooperation. We know that the good cooperation means, the term for the good cooperation is compliance. Which means that the patient is compliant with the treatment, the patient follows the doctor's instruction, the patient takes his medication as it is advised, as it is needed, as it is recommended by the doctor, and this is compliance. There is a newer, a more recent term for this cooperation, which is called adherence. Compliance is more an asymmetrical relationship. Adherence is more a symmetrical relationship. During adherence, the patient is educated, the patient is in a shared decision-making model, the patient knows why it is important to cooperate, and the patient not only follows the instructions he gets from the doctor, but in an equal position, the patient is contributing to the treatment. This is called the shared decision-making model, and the adherence is a term which we recently used for the good cooperation of patients with specialists. And there are two techniques, there are two ways how you can increase, how you can make better the patient's cooperation, the patient adherence. The first technique is psychoeducation, which means that you educate the patient what is his illness, what are the symptoms of the illness, why it is important to cooperate, why it is important to take the medication, and why is it important to involve in a long care with the specialist. And this can be educated to the patient, and this is what psychoeducation or pharmacoeducation means. There is another technique, there is another model, which is called the Motivational Interviewing, which is a kind of psychosocial treatment, which means that kind of reflecting attention, interest towards the patient word is very much important. Continuous empathy towards the patient is very much important, how the patient feels in the sick room, how the patient is threatened by the illness, how the patient tries to cope with the problems he needs to face with. So this is an empathic approach. And the third one is motivation, which means that it says here that during the motivational interviewing and during the motivation, you have to somehow reflect and emphasize that there is a discrepancy between the patient's non-adherent, maladaptive behavior and the patient-positive goals. So that, for example, the patient would like to have a long life with good blood pressure, and the patient don't want to have a stroke, and he would like to see his grandchildren to be raised up. This is a positive goal. But parallelly, the patient says, don't take my medication for hypertension. Why? And this kind of non-adherent, maladaptive, non-compliant, non-cooperative approach from the patient is in a discrepancy, in a contradiction with the patient positive goals. And in the motivational interviewing technique, this kind of discrepancy is very much put into focus, and this is emphasized in an empathic way. And this will lead to a better adherence. So psychoeducation and motivational interviewing are two techniques which can be both used to increase adherence and to reach a better adherence in the case of patients in all fields of medicine. So for general doctors, for general practitioners, for doctors from all fields of medicine, these techniques should be known and should be used because it can help you as professionals to increase the level of adherence and level of cooperation in the case of your patient. So, patients. So, with this, I would like to finish for today, and I would like to thank your attention. And today, so I tried to make a summary, try to give you a summary of psychosomatics and these aspects. So, thank you for your attention, and goodbye for today.